Save My Piggies, your life, your limb, your story. With host Dr. John Phillips and Kim McNicholas.
I'm John Phillips. I am joined today by my wonderful award-winning co-host, Kimberly McNicholas. And today's topic and the entire show is a Save My Piggies episode. So I'm super psyched about that. I know, Kim, you are as well. You know, Save My Piggies, we started it several years ago. It's dedicated to patient advocacy in folks that have peripheral arterial disease and other medical ailments. And it really allows them to tell their story in their own words. So we have the whole hour devoted to, I think, what's going to be a pretty riveting story. And we have multiple guests that are going to be joining us. So, Kim, I need you to tell me a little bit more about how this show is going to unfold.
Well, this is really about one of our friends in our network at the Weight of My Heart, Helen, and how chronic pain led her ultimately to some jail time. It's really how so many people with vascular disease have chronic pain and they don't get diagnosed early enough. And so they don't get the early treatment, and it just keeps getting worse and worse and worse and worse. And chronic pain can have a huge impact, not only physically on you, but also mentally. Many individuals who suffer from vascular diseases like PAD, peripheral artery disease, that circulation issue, as well as the chronic venous insufficiency, which is with the veins. You know, you have valves in your veins and they stop working and stop ushering blood back to the heart in an effective manner. That can also cause a lot of pain for people. So this ongoing pain can make people feel like a sense of helplessness and frustration. And, you know, as people try to regain their control of their health, you know, a lot of things can happen. And Helen's here to share her story. We also have vascular surgeon Christopher Stout, who is here with us. He's going to talk about these circulatory issues and how they can lead to chronic pain. And then we have a psychiatric nurse practitioner, Catherine Walker, who is the founder and CEO of Revitalist, which is a chain of wellness facilities across the US. And she is going to also be joining us as an expert. So this should be really exciting, but we're going to start with Helen's story as soon as we just have a few words of inspiration.
Dr. John Phillips' spectacular vascular moment of inspiration.
Well, you know, I apologize for not being here last week, but my father passed away unexpectedly, and he was suffering from Parkinson's disease. And, you know, it's really hard, and Kim and you, I think, can attest to this too after losing your mom, to see somebody that you love maybe not in their, prime and kind of dwindle away. But when they pass, you start thinking of memories, right? And you try to remember them when they were in their prime. And I remember I had to do the eulogy for my dad, and all these kind of emotions got drudged up again. But he was a man of few words. He was pretty humble, probably the smartest man I knew. But he always, his big tenets were like integrity, honesty, and empathy. And he actually made us, when we were kids at the dinner table, when we were kind of not being most empathetic people in the world, we'd have to go get a dictionary. And, you know, now dictionaries are online, and we'd have to go look up the word empathy and read it out loud. So, you know what, I'm going to do that right now, because I think empathy really plays into the topic of this show. A lot of times I'm guilty of this too. I see a patient who obviously has a medical int, and you try to be empathetic, but it's hard to really kind of like walk a mile in their shoes. So at any rate, the Merriam-Webster definition of empathy is this: the action of understanding, being aware, being sensitive to, and vicariously experiencing the feelings, thoughts, and experience of another. So that's to you, Dad. I'm reading the dictionary definition of empathy on the air to anyone who's listening. So kudos. And again, hope to see you soon. Not too soon, but sometime in the future. But anyway, Kim, there you go. Those are my my definition of inspiration.
Oh, I think that was absolutely beautiful. And I know, I like to feel like my mom's always here with me. And so I know that your dad is always with you. as well. And he's smiling at you right now for sharing those words of wisdom. And I wanted to say hello really quick to Catherine Walker, our psychiatric nurse practitioner and CEO of Revitalis, because I was watching her nod her head as you were reading that. Empathy is so important, especially as we go into Helen's story today and she starts to share it, because that's one of the things that we're really hoping for with, the folks that are involved with her story, that they can, show a little empathy and understanding, right, Catherine?
Yeah, Helen, bravo for you to be here and actually share your story. And, it's a huge piece of vulnerability, but that's greatly what we're lacking in society these days is the ability to be vulnerable in front of or with others. So Helen's story, I think it's going to be a great story, not only to show empathy, but also to have that connection, right? So that's the big thing, is we're losing connection because we're too much on data and different pieces like that. And we're forgetting what it's like to have that empathy, that connection, that feeling towards others. So I'm glad you're here, Helen.
And Dr. Christopher Stout, one of the things it's especially important when it comes to physicians and with that earlier diagnosis and making sure that you're listening to the patient and understanding what they're feeling, what they're going through, and see if there's a way that you can help them so that they don't get to the point that we're going to discuss, for example, with Helen. But her story is not isolated. And that's because, in my opinion, there isn't as much empathy as there should be in the vascular space. What are your thoughts?
Yes, I agree with you 100%. And I see this on a daily basis. For example, I have a patient that was supposed to see an interventionalist and he's scheduled 3 months out. The guy's got a ulcer on his toe and his ABI is around 0.5. And he's been wondering and worrying whether or not he's going to lose his leg. In addition to the physical aspects that the peripheral artery disease has inhibited and affected his quality of life, it's also a mental aspect. These folks with this disease process have a significant mental, fatigue from dealing with it and dealing with navigating the hospital systems, the healthcare systems is very difficult for them. It could be frustrating. And then you throw depression and a feeling of hopelessness on top of that because they can't get in, they can't get treated. And that is something that we need to address as healthcare providers, because it is a significant disease that is clearly underrepresented in the literature from a mental health aspect.
We'll come up next right here on the Heart of Innovation and our Save My Piggies special. We are going to hear from Helen. You don't want to miss her story, so stay with us right here on the show.
You're clear.
Okay, great. So we're gonna kick things off. I didn't want to just throw you in there, Helen. I wanted to get you comfortable with everything that was happening and meet everybody who is going to be talking and just see how easy it is. So you feeling good? You feeling ready?
Yes.
You
Can you hear
look
me?
great. Yep,
Yeah.
you look great.
Helen,
Thank you.
this is real simple. It's just a conversation. We guide you through it.
Yeah.
If I can do this on a regular basis, you can. So
Okay.
And we have Joe there. Big hugs, Joe.
Very good with the empathy too. That was spot on. That was very
Right?
good.
He's probably mad I don't have that definition memorized, but nonetheless.
Who says you really didn't have that memorized? You were walking through the motions that he would want you to walk through, and you educated others on how
1
to
minute
do
to
the
lair.
same.
That's true. That's true. Gotta look on everything has a silver lining.
So I was thinking I could take it back and just start right in introducing everyone to Helen.
Yep.
And then of course, Catherine, Dr. Stout, you don't have to wait for a question. The first time you speak, just jump in and say, hey, Dr. Stout here, or nurse practitioner Catherine here. Just that first time so people get your voice.
Yeah.
And then
yeah,
there's,
you don't
oh,
just,
sorry, just in the
20
chat,
seconds.
Colin does a countdown for us. So just be aware of that with respect to breaks.
yeah, you'll see the countdown in the chat.
Yeah, and Dr. Stout, I can tee you up. I actually have a couple of thoughts.
Okay.
You have exactly what you're just talking about with pain.
It's
and mental
8:60 a.m. The Answer.
Save My Piggies, your life, your limb, your story. With host Dr. John Phillips and Kim McNicholas.
Hi, everyone, and welcome. We have a very special story to share with you. We have Helen, who is with us, along with her husband, Joe, and Helen is going to be sharing her story. We have, of course, my co-host, Dr. John Phillips here. We have a psychiatric nurse practitioner and CEO of Revitalist, a chain of wellness companies across the U.S. She is here, and also Dr. Christopher Stout, who is a vascular surgeon. Helen, thank you so much for your bravery in joining us and your courage. And I know so many others are going to relate to you and be inspired by you as well. And as Dr. Phillips mentioned in the first segment, this is really all about empathy, right? Would you want to start us off with your experience? You were diagnosed with peripheral artery disease, which is the circulation issue, mainly in the arteries, as well as chronic venous insufficiency, which impacts the veins. So you really got a double whammy there, and you were in pain.
Yes.
So start us off when you started feeling these symptoms and what the doctor responded to you.
Everything came on quick. I was walking great in January. Everything came on quick. January 27th, my daughter and I were going on vacation, and I couldn't walk more than a few hundred steps. And she finally said, she's a nurse, and she said, you need to go to the emergency room. So I went to the emergency room, and they diagnosed me. They said, when you get back to Georgia, go to a doctor and get treated for this. So I got back to Georgia and tried to find a doctor. Nobody would take me. I didn't have insurance. And finally found insurance. And you found me a doctor in Jacksonville.
Mm-hmm.
And he did diagnose me, but he really didn't give me anything for pain or anything. And he just sent me on the way. I'm constantly in pain. And I would tell my husband, my son, I couldn't walk. It hurt to walk. It constantly in pain, excruciating. And
Right,
we took that.
So
Only
Helen,
walking about a tenth of a mile, right? You could only walk a tenth of a mile before the pain would just be crippling.
It would be terrible. Going around the grocery store, I had to take a buggy. Going outside, I had to stop and try to find a place to sit down. It was terrible.
so just so I understand the symptoms and the timeline, you were, prior to the 27th of January, you were walking fine, and then something acutely happened.
Fine.
Is that right?
I was walking great. In
Okay.
fact, my daughter flew to Jacksonville to spend the holidays with us. And I walked 3 miles one morning while she was still asleep, and no problem at all. No pains anywhere.
So Chris, for me, if I hear that from a patient, acute onset, change in ability to walk, to me, that means something acutely has changed, as opposed to somebody who might have some chronic peripheral arterial disease and they've built up collaterals and things, and kind of they've adapted to it over time. And that's a red flag, in my opinion, meaning that patient needs to be evaluated ASAP and potentially treated ASAP. Again, I can't speak for what the assessment was back when you were on vacation, but so you just, Helen, what were you, I guess, told that you had?
Well, down in Key West at the emergency room, they said I had peripheral artery disease. And that's all they said. And they said, when you get back to Georgia, you need to get it checked out. And then when I got the doctor in Jacksonville, he said peripheral artery disease. I had a 50% blockage from my thigh to my stomach. and that a lot of it was also caused by vein deficiency.
Yeah. Yeah,
They had scheduled a bunch of diagnostics for the rest of the summer, which it turns out, because of the lack of insurance or the wrong insurance that she had ended up purchasing, none of the diagnostics, not even the consults, were covered, and they wouldn't be covered going forward. And so that became an issue. I'm sorry, Dr. Stout?
Yeah. Hey, Chris Stout here, vascular surgery. Listening to what's going on, and with the acute onset, that's more of an urgent thing that needs to be addressed. The things that come to my mind with the, something that comes on all of a sudden, you definitely got to worry about a clot that either formed in an artery, or a clot that had gone from the heart or traveled from somewhere else, the heart or the aorta, that went to the lower legs. And that has implications that needs to be addressed, because those clots can go other places like the brain, or to the heart, and those need to be addressed. So I do think that, I think that insurance really kind of hurt you pretty badly here.
Yeah, and we're going to share with you coming up next, right here on the Save My Piggies series on the Heart of Innovation. We are going to hear what happened after Helen ended up having trouble with the insurance and is experiencing chronic pain. You don't want to miss it, so stay with us.
3 years ago, my symptoms started with...
We're clear. Kim, we still have a little bit of time to go for stuff, but I got you.
No, well, when did you put in that you had 30 seconds?
That was at 14.
Yeah, I got concerned. When did you, so that's what I was concerned about, is the 30 seconds that you put up. Was that to mean out of break?
That was no. The one you see beforehand, that was the before section. I haven't started the 2 minute, the one for this section. So we got out about right now we got about 2 minutes earlier than usual.
I see what happened. Sorry about that.
No, you're fine. That just means we have a little more time for the next section. Now for this next section,
like more time.
Play the My Piggy Stinger again when we come back in?
Sure.
That will never get old, Colin.
Sure. We like that.
So do we want to just continue? Helen, do you want to continue your story?
Sure.
Okay. But so I guess I'm curious. So like, I have to imagine at the whatever emergency room or wherever you were in Key West, they must have assessed you and said there was nothing critically wrong with your leg as it pertains to blood flow at that time.
They did an ultrasound, and they said there was no clots, but that there was claudication.
Okay.
Mm-hmm.
So is this part of the pain? Maybe because a lot of times, and I think Dr. Stout can attest to this. We see patients that have peripheral arterial disease. Yes, it can cause some discomfort, but then there may be some musculoskeletal issues or something else that's going on that can cause pain as well. I mean, is that what they were trying to tease out for you?
I don't know. When I first went down there and got it, and went to the emergency room, I was only having pain in the calf, and that's why they checked for a clot. And they came back and they said, no, there was no clotting, but I had this peripheral artery disease when I go back home to get it checked out. But then after I got home, the pain was going from the ankle all the way up to the hips, and it would move, different places.
You haven't had a CT. Sorry, you didn't have a CT angiogram yet, right? You didn't have the CT scan. See, she couldn't afford the CT scan yet. So we really still haven't gotten the full story.
Did they only do an ultrasound on your calf?
Yeah.
The whole leg.
At the emergency room, yes.
At the emergency. But Dr.
Schimmel did a couple of different tests.
Yeah, he did the ultrasound.
He was the one who found the clot between your abdomen and your thigh.
Yes.
The blockage, yeah.
Yeah.
Well, narrowing, but they haven't done a CT angiogram yet because she has all these bills piling up.
20 seconds.
No insurance, chronic pain, no answers. John, do you want to build up with that going into it, and we can get to Helen, and then we'll get to Catherine to start what was going through her mind.
Sure.
5519 or visit standwithisraeltour.com.
860 AM, The Answer.
Save My Piggies, your life, your limb, your story. With host Dr. John Phillips and Kim McNicholas.
Welcome back, everybody. We are continuing our conversation with Helen, who before the break was telling us about what sounds like some relatively sudden onset changes with respect to leg pain, ability to walk. She had an evaluation when she was on vacation, and they told her she had peripheral arterial disease. And now, Helen, you're back in Georgia. You finally got insurance, and you're hoping to get some answers. Is that right?
Yes. I got a doctor down in Jacksonville. He did a couple of different tests, and he said it's peripheral artery disease. I had a 50% blockage between my thigh and my stomach, but that he wouldn't touch it because it was only 50% unblocked, and that most of the rest of the pain was vein deficiency.
And so, I honestly, if you came to me and I read that ultrasound and assume it's done correctly, 50% blockage, that can cause some symptoms for folks. I guess I'm interested how they made the leap to vein problems. Oftentimes folks that have vein problems, they can have some swelling, aching, heaviness in the leg, some discoloration, some visible veins. Did you or do you have any of that? Or they must have done some tests. They must have done some.
I just told him that I had a lot of pain in the ankles, and he ordered a test. And then he said the test came back and it was vein deficiency.
Okay. So now you have kind of two diagnoses, but still you're in a fair amount of pain.
Yeah.
Did they try to say, well, maybe this isn't all vascular and maybe there's something else going on? No.
No, but she's sitting there.
Else.
She's in severe pain. It's debilitating. It's crippling. She has more tests that they wanted to do that were extended throughout the summer, and the medical bills are piling up because what happened with your insurance?
Well, I got the insurance online, and they said that I could go to any doctor, any hospital, and I also bought the prescription plan, and they said it would take care of prescriptions. So it was $187 for the insurance, $29 for the prescriptions. And every time I went to the doctor, it wouldn't pay for anything. And so we called them up and we said, what's going on? They said, oh, it should be paying for everything. And it was paying for nothing. And so
Helen, talking about your pain and such. So this is Katie Walker. I'm a nurse practitioner, but I'm also a CRNA by trade as well. So I have an anesthesia degree, and then I help with the psychiatry piece too. So, talking about like peripheral artery disease and all your venous insufficiencies and stuff, and everyone who's on this station, right? And I know Dr. Stout knows this immensely too. When we say the word pain, we look at it as like a very unilateral definition, right? Like, oh, you're in pain. What happens with people when they have, artery and venous deficiencies, there's like 5 different levels of different types of pain that you guys are dealing with at any given time. So, there's one type of pain called like tourniquet pain, right? So that pain actually can start when there's kind of a blockage there, and it can actually start about 45 minutes later. And it's just this aching pain that just hurts, which I'm expecting, a lot of people who may have artery and venous issues have that, right? So that's one type of pain. There's another type of pain called reperfusion pain. So when there's more blood flow coming in and there's like lactic acid, like after you work out, sometimes you may get a buildup of that. Well, that's a different type of pain. Well, now they've also proved that our mental health and our pain are directly related. So when we're not feeling well, we have more pain. And if you think about it, when you have the flu, you don't want people to touch you a lot of times like that, right? So you've got that, but then you also have to think about the trauma that you've already now been through because of what the system has done, right? The system has failed you currently. And unfortunately, with the system failing you and trying to get you any type of relief from your pain or intervention or whatever else, you felt like you had to take measures into your own hands to advocate for yourself. And, you know, it's really unfortunate because that's, you know, that's a great reason for this radio station, is because it's helping to increase access. It's bringing the professionals to the front to where everybody can start like making sense of what's there, what makes sense, what doesn't make sense. Because, you know, Dr. Phillips and Dr. Stout and myself working in the medical field, we know your story doesn't make sense as to the way it's supposed to be. But others don't know that. Others don't know that, you know, there are advocates out there. There are pathways to go to try to get people to help advocate for yourself. But when you're trying to take on the system 100% by yourself, it's hard. And you know what that leads to? A lot of times, I mean, actions like you took, you advocated for yourself, but also what happens is people get lost in the systems. And a lot of times this is when people kill themselves. You know, so it's very, very unfortunate that people take that action as well, but they feel lost. They feel stuck. They don't know what else to do, right? So you made a decision to advocate for yourself, but we've got to do a better job at helping people to know, like, this is right, this is wrong. Here, we will help you, because people should not be in your situation right now.
Oh, and so what did you do? How did you decide to advocate for yourself and to try and find some sort of relief?
Well, my husband and son and I were on vacation in Canada, and I was in so much pain. And my son, especially, he doesn't really get the pain either. And so I'm telling him I'm in so much pain. And he's like, oh, you'll be fine. You'll be fine. And I'm like, I can't even, I got to sit down on a bench every couple of feet. This is terrible. And so then we got home, and our car broke again from driving back and forth to Jacksonville. And we got a big bill of $3,000 to fix it, my husband's truck. And I said, this is too much. I'm a burden on my husband and my son. This is just too much. And so I went into Walmart. I put a bunch of things in the buggy, and I said, you know, I'm gonna put myself in jail, and maybe that'll take care of the medical part of it, so they don't have to worry about me.
Coming up right here on the Heart of Innovation, you're going to find out about what happened next in her story. So stay with us.
Medical Notepad brought to you by...
You're clear.
So
you're doing such a great job.
Yeah, you're doing awesome. And I have to imagine that's a pretty difficult decision that you had to make in Walmart. I'd love for you to share kind of what was going through, a little bit more about what was going through your mind. And I have to also assume that you've never shoplifted or done anything like that before. And
no,
this is good stuff, John, to start the segment off with.
Yep. Wow. Okay. Fantastic. So you
I know it's so.
You did this with the intention of getting caught. Is that right?
Yes, I wanted to try to get some medical attention. I figured if you go to jail, they have to take care of you, right? It didn't turn out that way. They got me my blood pressure medicine. They got me my blood thinners. They got me my cholesterol medicine. But here at home, I'm taking Tylenol and Advil like every 2 hours. When you're in jail, they let you have 2 pills a week. That's it.
I even had to call and try and explain to them, their medical staff, the suffering that people go through with this. And they have these very strict policies on distributing any sort of even over-the-counter pain medication.
Sure.
And so here she is pacing the jail cell all night long, not able to get any sort of relief. And it was just awful. And it's a small town. So normally you would have in a regular big city, the arraignment, the next day. And in her town, she had to wait for the magistrate like for 3 days. And so she was just stuck there.
Wow. Well, this will obviously be a good story to tell on the air.
Yep. So you're going to have to repeat yourself a little bit, Helen. And then also it'd be interesting because I want Catherine to kind of dig in, because as she's in the store and this has happened, I'd love for her to kind of dig into what was really going through her mind. I mean, she knew exactly who the loss prevention person was. And the fact that she actually, if you think about it, she did make it past the point of sale, but she did not make it to the door. She actually stopped at the door just beyond the point of sale and didn't move, just waiting for someone to just catch her. So having her tell that part of it, she never had any intention of leaving the store with those items, and they still arrested her.
Well, you should let also know, Helen, that they don't have a great anti-theft protection there either. Sounds like you could have walked out pretty easily.
Did you grab anything?
The problem is, and she couldn't even walk. She wasn't even walking very fast.
That's true.
She can't walk fast. That's just it.
I mean, the fact that anyone would think that she was really shoplifting, and the fact that they even called the police, I mean, you would just think the guy would have said, what did he say, Helen? He said, I think you have something that belongs to us.
Yeah.
She's literally just standing there. She's just standing there. And she's like, yes. And he's like, okay, we'll just stay right there and wait for the police. And she's like, oh, okay. And the police come. I mean, this is totally ridiculous. So we tell this part of the story, Helen, just like this. I mean, it is totally ridiculous.
It's I mean, because we've all seen surveillance video of people shoplifting and they grab and run. Like, so, yeah.
Yeah.
And then there's Helen.
Oh.
She had no intention. She had no intention of walking out of the store with any of those items. I actually am really shocked she got what she wanted, which was to get arrested, because
you hear all the time that people get free health care when they're in jail.
Yeah.
Everyone does that. You know, they are. I mean, I don't know the details, but you know, even with hormonal replacements, right? I mean, people who are doing sex changes and such, those get covered in the federal system. I don't know about the state system, but yeah, it's interesting times.
Now, let me ask you this, Helen. Did you grab like some high-end stuff that?
No, it was just.
I mean, if you have a pair of socks and some sunglasses, why don't they just let you put it back?
It was over $800, so it was classified as a felony.
I see. Did you know that?
She got the good stuff.
Did you know that?
No, I didn't know that at the time. I was just throwing things in.
Oh, okay. So I wonder if that actually probably helped you get arrested. If it would have been under that, I would imagine they would just let you go. Like, it's not worth the time.
I don't know.
Interesting. Well, you'll be telling the story, so.
Yeah, you'll be telling the story.
That's good.
It's so crazy. And Chris, you're always.
We'll have to get into Chris, like how you obviously got involved, because
he didn't get involved necessarily. He just offered to be an expert witness.
Oh.
Just for vascular disease, and so that would be.
But so an expert witness for Helen through her attorney, or
if it comes to that, we don't know.
Oh, I see. Okay, gotcha. Okay.
Yeah. It'd be interesting, just his perspective on how vascular disease and how painful it is, and the lack of the diagnosis, the lack of the treatment early. I mean, these people are suffering in the worst way possible. I mean, it's just unconscionable.
It is crazy. And I see it daily when being in private practice now. I fight with insurance companies and I do peer-to-peers all the time. Like, hey, guys,
10 seconds.
You're going to lose a leg if we don't fix this. You know, and these are CLTI patients. So
your hands are tied because they don't give you any options for payment.
Yep.
Here we go.
8:60 a.m. The Answer.
Save My Piggies, your life, your limb, your story. With host Dr. John Phillips and Kim McNicholas.
So before we went to break, Helen was telling us how she was so desperate for some type of medical care, had issues with insurance, wasn't really getting anywhere. So you hatched this idea of going into a Walmart and shoplifting with the premise of getting caught than potentially going to jail to get medical care. Is that right? So walk us through that thought process.
Helen, I think we just lost her for a moment, and while she's getting her, are you there, Helen?
Helen, you're muted.
Yeah. There you go.
Go ahead.
You got it?
Yeah.
Okay.
Yeah.
Go ahead, Helen. So
yeah, I thought that if I were to get caught and go to jail, that it would pay for the medical, and that my husband and son, that I wouldn't be a burden to them, because the bills were piling up. The car was breaking from driving back and forth to Jacksonville, and I didn't know what else to do. I thought, maybe going to jail, they would have to provide for you, so that medical stuff would get taken care of anyway. But it didn't turn out that way. They gave me my regular prescriptions. They asked me what I was on. And at home, I was taking either Tylenol or Advil every 2 hours. And in jail, they give you 2 tablets a week. And that's it.
And Helen, this is Katie again, nurse practitioner. So one of the things, like when we get to desperate times, right, which we all do in life sometimes, is when we become more reactive with their decision making. So, you're thinking about your thoughts and such, and thought about, well, what's going to be the best way? And I think we all know that, we hear all the time, well, if you're in jail, they have to provide medical care to you. Like, that's one of your rights, so I'm sure that's what you were thinking. And, unfortunately, what happens with any type of violence in the United States or wherever, it can be self-inflicted violence, or then violence to others, or something like that. And a lot of times those are reactionary actions that people take. So exactly what you were just saying, I felt like a burden on others. I felt like the bills are piling up. And, so it would have been best if you could have sat back and talked to others and be like, hey, do you think this will work? But, you didn't want to disclose your plan to anyone just in case it didn't work. So tell us a little bit more about your thought process with that, like recognizing that, yes, you might get arrested. Yes, they might have your, pay for your care. Could you see anything past that?
No, I just wanted to get the bills off my husband and son, and just get some kind of medical care to, try to get rid of the pain, but also, not be so much on them.
Yeah. And Dr. Stout, can you tell us a little bit about, recognizing that there are like systems out there, and even Dr. Phillips, you may know this too, is like, where do people like Helen go when they're seeking help and they don't have financial means? I mean, I know we can go to the ERs, but sometimes, it sounds like she already tried that route and she still didn't get effective treatment.
Yeah, that's a very good point that you bring up, that when you don't have healthcare insurance, a lot of these patients will just do what they have to just barely get by. They'll run to the emergency room because that's the only place that's going to accept them, unless they can get plugged in with some type of community type clinic that's subsidized by grants, etc. But even most of those primary care facilities that are subsidized, that take patients that don't have the insurance, they still are very hesitant to get the patient sent to a specialist, because they have a difficult time trying to send a patient to a doctor who has no money to take care of it, even if they can get a grant to help pay for some of it. I've had discussions with our local community care clinic folks, and they're very good and very excited about getting all these patients on board. And I told them, I go, hey, I will take care of these patients for you guys. I have no problems with that. And from a business aspect, yeah, definitely we lose some money in it, but we're not here to become millionaires. We're here just to live a life and break even and keep the lights on. And unfortunately, a lot of specialist clinics are protected by hospital administrators and other administrators who don't allow the physicians to do what they really want to do, and that's take care of everybody.
And Chris, you bring up a great point, that unfortunately people who have limited means or bad insurance or no insurance use our emergency rooms as their primary care. And we saw, I don't know about you, but when COVID hit, nobody rooms, and these folks were sitting at home who should have sought medical attention and didn't, and then they came to us even sicker. So that's a symptom of a larger problem within our healthcare system, because the emergency room can't be a person's PCP or their family care doctor, but yet, like you said, a lot of these folks don't have anywhere to go.
Yep, exactly.
And unfortunately, with the access piece as well is, Helen, you took extraordinary means to try to get free health care. But there's a lot of people, I'm sure, that are in your same shoes who would have also sought out additional substances on the street because they're cheaper. And, and we know, all right, we all know there's fentanyl on the streets. There's every type of substance that you could possibly want on the streets, and it's cheap, right? So I'm sure that there's other people, if they don't have access that way, they're taking out, other sources like that. So did you have any other thoughts, Helen? I mean, instead of going into the store and taking some things, was that that was what your primary focus was?
No, I didn't have a primary care physician. And when my daughter told me to go to the emergency room in Key West, I thought that was way too expensive to just keep doing that. So I didn't want to do that. And then going to the doctor in Jacksonville, he ran a lot of tests and everything, but he wouldn't give me anything for the pain. He said, you don't need it right now. It's not that bad. I've seen people worse than you. And it was just very frustrating. And so
there's
I thought,
that empathy piece.
Going to jail, they would give me something for pain.
We have been talking to Helen about her story. She was experiencing chronic pain, saw no light at the end of the tunnel for getting relief, medical bills piling up, et cetera, et cetera. She goes into a Walmart, starts picking up some items, and she walks to just beyond the point of sale and stands there. I mean, this is a woman that literally could barely walk. She was hobbling, and she stood there at the point of sale right there beyond. And Helen, you were waiting to get caught. You had no intention of walking out the door, only to get caught. And what did the loss prevention officer say to you when he walked up to you?
Well, he walked up to me and he said, I think you have something of mine. And I said, yes, I do. And he said, okay. And then the police came in the front door, and the police told me to wait with them while they went and counted the stuff. And then the policeman said, why did you do this? And I said, because I'm a burden to my family. I'm in so much pain. I wanted to get some kind of medical stuff. And he's like, okay. He's like, well, let's go sit in my truck so that it's not so painful.
And then they took her in. Helen, where are you at right now with this whole process and your feelings and what is going through your mind today?
Well, I didn't get any relief in jail. So I'm back home trying to get some relief at home. I got the circulation machine that I put my leg on, and got the Tylenol, got the Advil, and but worried about the upcoming trial, because what I thought would get me relief just didn't. So yeah, it's worrisome.
Yeah, and now you have more financial problems with the legal system. So just throw that on the truck, the pain, trying to get in. It's just, I bet you're frustrated beyond belief with all of this.
I am. Yeah.
I have to, can I interject? This is kind of like all of our stories, Helen, is none of this got dropped as a bomb on us. It started a little bit at a time. So the very first time you were diagnosed, it is just a progression in that insanity and the roller coaster that we live on, being diagnosed and having to go through and not being taken care of here or being taken care of there, and having to go to this doctor and that doctor. And like you say, having to deal with family and life. You still got to pay bills. You still got to function as a human being the best that you can. So it's not like we woke up one day and we were in this bad position. It is a progress that we, as I think, as patients and doctors, have to work together in preventing to stop from getting to that point.
That's for sure.
What you just said, Douglas, is like, the repetitive feelings of this when you kind of go on the highs and lows and all those things, that it's something called complex trauma, right? So complex trauma is just a repetitive occurrence of the same situation. So even if you all feel, maybe if you're completely out of pain, which hopefully sometimes you are, maybe you never are, but if you feel that little piece of pain start to creep in, that causes, almost a traumatic response, because you don't know how to stop it yet. So I'm sure that ties into everything that you all feel. And not only are you dealing with these chronic pain issues that we don't have great help with right now, but you're also dealing with a traumatic mindset, right? So when the brain feeds into that, it makes the pain worse because you're scared to death of the pain as to where it may go,
So
Helen,
go ahead, Larry.
Well, Helen, I would like to just say to you, I'm glad you're free and try to stay free. But before you get to that point, reach out to some of those family members and ask, what should I do in this situation? Not saying everything you do is wrong, but I'm sure you're intelligent enough to say, I'm not going to win in this situation. I'm going to gain attention for the wrong reason. And I would like for you to reach out to, one step away and away to my heart. I believe we could have solved that problem just by communicating.
Yep.
And Larry, I think you had a really good point there, to ask others. But unfortunately, sometimes I think when we get in that survival mindset, we don't even think that way, So, I mean, now that they know that this exists and there's support here, like that's one more person that knows about that. But, what about the people out there who are in Helen's situation who don't know, right? They don't know the next step. And I don't know either. When we tell everybody call 911 or go to your closest ER, and Helen did that, but that didn't help. So it's like, how do we help people to increase their advocacy and their awareness and know that there are steps out there and, they don't have to take these actions, to try to take
That's the whole point, Catherine, is you nailed that one part on the head. As a recovering addict, as somebody who shot up, who sold himself on the streets, who did all that insanity, when you're in that moment, it is common sense goes right out the window. You can stare at all the solutions you want to, but you're when you're caught up in that tornado, that's all you see is a tornado. And that's the truth. It's hard. It's easy for us to say now, I should have asked for help. I should have done this. I should have done this. But when I'm living in that tornado, that's all I'm living is that tornado, period. That's it.
And that's exactly, and that's what Helen was feeling. Because when I was talking to Joe, her husband, he was like, this is so out of character. And you even see Helen is the sweetest lady. We had worked before together. Joe, what was the conversation with Helen like after you got home? Did you sit down and say, what the heck? I just don't understand.
It was like that, but you also have to show compassion since this was so far out of character that, I understand you're in a lot of pain. Whether she's standing, sitting, laying down, there's no relief at all. So, so I know it's past the point of no return if you're going to this drastic a measure to get this done. But please remember, you've got a support system. You've got family members. You've got friends. All these people are counting on you. You've got a support system. We're here for you. Please never forget that.
And, and the blessing of this, Helen, is the action that you took allowed you a second chance. Because just what Douglas was saying, people who have addictions, people who try to take their own lives, sometimes they may take that one last hit and they die, or they may effectively kill themselves and they don't get a second chance. So that's the piece that we just have to do more education and say, there are communities out there, but gosh, maybe I was talking earlier on social media, we're very dagger throwing, to people. And we don't have that sense of like, it's going to be okay. We're going to be here with you. We're going to walk with you through this. We understand that you made a bad decision, but it's going to be okay. You know, we don't have that right now. It's very finger pointing and very damning of a system that's out there.
Joe, it has to feel a little endearing, that she loves you and your son and your daughter so much that she didn't want to be a burden, that she was really in the middle of her pain and not seeing any relief or any light at the end of the tunnel. She didn't want things to fall on you. She didn't want you to feel the burden and right, wrong, or indifferent. You had to feel so much love.
Yes, I feel so much love, but also when you say your vows, you say for better or for worse. We're in this together forever, for better or for worse.
No, it's sweet.
That is really, really sweet. How does it feel to hear that, Helen?
It feels good. Yeah, after I got home, he said, you didn't have to do this alone. I'm here for you. And yeah.
Yes, Helen, I think you'll be fine in court. Just explain to him, just say how you felt and how you felt, your reactions to what you did. And it's not like you went off the property with it, even though
No.
once you cross the door, it's considered theft. But you explain to him, I don't need probation. I don't need nothing but counseling, if anything. Because
I'm
if you
not
get
doing anything like
probation-
that again.
No, well, we pray that you don't.
I promise you, she's not doing
Just
that.
get on Zoom and bring us all with you to court.
I will
Yeah.
do it in a minute.
Yeah, tell the judge to get on there too. And Helen, you tell him, you said you walk in my shoes and I walk in yours. Then you tell me
Yes,
what you would do.
I mean, that's exactly right. If anybody else could see the pain, I don't know it because I don't have it, but I see what she's going through. So I applaud each and every one of you 100%, because I mean, it's a struggle every day just to do simple things around the house.
You know, and talking about that stuff too, Joe, you know, is with pain, right? So we do something that's called like a visual acuity scale, right? To where, what's your pain? 0 to 10, 10 being the worst.
That's
And
what we do every morning.
Everyone's different. It's subjective, you know, like we're not really good with helping people to understand pain. So whenever I talk to people about pain and I'm trying to figure out, is their pain getting better or is it getting worse? Pain's very complex, very complex. You know, so I see a lot of people will have a lot of pain in their shoulders and their hips. And sometimes that's stress. You know, you actually hold stress in your shoulders and your hips a lot of times. But then other times too, it's like the pain that you are having, it can be burning, stabbing, stinging, pressure, throbbing, deep, you know, like you have all of these different types of pain regimens. And what I've seen with individuals, especially with ketamine, which is the medication I use primarily with people for pain, is their pain, if we don't stop the pain, it keeps duplicating over time. And that's the neuropathic pain aspects, right? Which is sometimes even called like phantom limb pain. You know, the anesthesia, we don't necessarily understand phantom limb pain as much because there's not an area. If you don't have a right foot, we want to go to your right foot and block it, but we can't because you don't have a right foot. But we're seeing that the brain's actually causing a lot of these pain symptoms. So really, as a society, what we need to do is to make pain to where it's a very simple, but a very complex chart to where it shows here's the different types of quality of pain. Here's your quantity of pain. Cause I'm sure Helen, when they say, oh, your pain can't be a 10, that's like the worst of the worst. And you're like, no, it's a 30 right now, you know, and we just have not developed the system to where people can truly understand and feel heard as to what they're trying to describe with their pain.
Thank you. That's
Good
perfect
point.
right there.
And also, Joe, I appreciate you being very strong with your loved one, because any weak man would have walked away and said, I'm with a crazy lady. But you sticking by her, that's a good thing.
Well, I agree. She is a crazy lady.
No, I didn't say that part.
Hello, everybody. My name is Ian Wilson. I'm an interventional radiologist. First of all, I just want to say Uh, what a brave thing you're doing here, Helen, and telling your story and the way that you sought to advocate for yourself, as atypical as it is bravery kind of incarnate, right? I mean, you put yourself in the system because the medical system was failing you. So you entered the legal system, I just wanted to ask you, how soon in your experience with your condition was pain the primary issue? Was that how your vascular disease presented as pain? Because the reason why I'm asking that is I also have a second question for some of the other medical practitioners on the call, is that how soon in the presentation of folks with your condition, with mixed vascular, meaning arterial disease and venous disease, should we be starting to think about a pain control regimen in addition to what we may need to do for your vessels? So, but back to the first question, which was, how did your condition present?
Well, the pain came on January 27th, and it was only in the calf. And so I could walk a little bit, but it was coming on quick. But I would say about 2 months later, March or April, the pain was everywhere. It was from the ankle all the way up to the hips, and it would just move, and it was just constant pain. And so, yeah, it started getting worse.
Mm-hmm. So it was the initial pain that kind of brought you to attention. And
Yeah.
so, a lot of times, we medical practitioners are guilty of being sort of paternalistic, right? We tend to tell people what they're experiencing, not listening to what they're experiencing. We say, oh, this is what's going on with you, but you know yourself better than anybody. We may know why you have a certain, symptom, but you know what's wrong with you, right? And so, but we often try to reinterpret that, and say, well, this is what you're actually, what's going on with you, instead of, just listening to what you're saying. But I think we need to start thinking about pain control for people with vascular disease more so than we're thinking now, because yes, the treatment is revascularization in some cases or closing down bad veins, but there's a pain component that we often don't address. And we kind of throw our hands up and say, well, we've done our part, and well, the rest is on you. You're still having pain,
Just like we were going on vacation the first week in May, and we were going to Canada. And I told my son, I said, I'm not going to be able to do a lot of walking. I'm in so much pain. And he's like, oh, sure you can. Sure you can. And I had a doctor's appointment 2 days before we went on the cruise. And I asked the doctor, I said, can you give me anything for pain? Because we're going to be doing a lot of walking. And he said, no, we got your results back. And there's people worse than you. You're not that bad. And he didn't realize how the pain was.
Well,
this is something.
Sorry, Kim, go ahead.
I see this. No, I see this all the time with so many patients around the world who have peripheral vascular disease. Of course, that's the combination between peripheral artery disease, the arteries, the circulation issue there, and then chronic venous insufficiency, which involves the health of the veins. But the doctors don't seem to understand the debilitating nature of this disorder. And I don't know where the problem lies. I ended up sharing Helen's story with at the request of and with permission, from Joe, her husband. And there were a couple of doctors from the United Kingdom that jumped on and completely missed the whole point of the story itself, which was, here is a patient who is experiencing chronic, crippling pain without any sort of solutions. And their comment on this thread was only about the fact that here's a patient, I don't see any signs of critical limb ischemia. even if there were signs of critical limb ischemia, walking's the best medicine, medication's the best medicine, and this person shouldn't be treated at all. Where's the empathy? And then the second doctor just affirmed, oh, he's right. And I'm thinking to myself, yes, we all agree that when you have the initial stages of these diseases, walking can be the best medicine. Medication is the best medicine. But the reality is, we didn't catch this in the earlier stages. It doesn't matter where she is at in her stage. She has crippling pain. Let's figure out what to do to give her some relief. I'm not saying it's pain medication. I'm saying let's expedite the diagnostic process. Let's help figure out what's going on, get to the source of it, maybe get her into physical therapy, get her into water therapy, if it might help at all. Let's move things forward faster and listen to the patient to help them get relief. Because as who said, was it Larry earlier in this broadcast said, you have not walked in my shoes. You don't know how I'm feeling.
Exactly.
And it is serious pain. Pain is a reality. And where is this gap? Why can't we get these patients the relief that they need?
It's not been created, Kim. And I think Dr. Wilson can, help reaffirm this. But when we say pain, like I said earlier, it's very unilateral. We hear pain. What's your pain right now? 6 down to a 4, good to go. And that's it, right? So we're unfortunately we're dealing with a situation in medicine that needs to be addressed. There's and Dr. Wilson, maybe you can answer this. I was Googling it right now, trying to see if I could find the answer. But so we have acute injuries, right? There's pain associated with acute injuries. That's normal. Then you heal from your acute injury, you have no pain. But we're seeing now that people are healing from their acute injuries and they still have pain. So what we like to do in the OR is we like to take you back. We just keep taking you back like 100 times. And we're going to say, anatomically, everything's fixed. We don't know why you have pain. And then the person will still have pain. Well, we'll take you back again. We'll say, you're fixed. We don't know why you have pain. So now we're seeing there's so much neuropathic pain that's involved in this. And a lot of times it's directly related to trauma. So there's different types. There's something actually called CRPS, complex regional pain syndrome. It actually it's more commonly in females, and it can happen in your acute limbs, more so, right, in your wrists and your ankles. So I was trying to see, and I don't know, and maybe Dr. Wilson can answer this, but I have no idea how quickly neuropathic pain develops after a direct injury. It could be Helen, to where you actually had this injury, because when you say it's moving up and down your leg, like if your narrowing is, not changing and it's moving up and down your leg, that makes me wonder if there's some neuropathic aspects or something like that going on. And, and all the pain medicine that we have right now, it's not directed to neuropathic pain, except ketamine. And I love ketamine. It's a great drug. But that's something too that nobody's looking at. So somehow we've got to develop protocols to help people, because right now we're not, and we're doing a huge disservice. So Dr. Wilson, I'll hand it over to you if you want to add anything to that.
Yeah, absolutely. Thank you. I'll just go out and say it. I think we're afraid to treat people with pain.
Absolutely. We're afraid to go to prison.
We're afraid to take their symptoms seriously. Yeah. We're afraid to manage them. I'm not a pain specialist, but I've got lots of friends who are, and I have no hesitation sending someone to a friend of mine if that's their expertise. I'm not the doctor for everything. I'm not a brain surgeon either. I'm an interventional radiologist. I do a specific thing. That's it. I don't deliver babies. But there are folks who do a variety of things, especially manage pain. And we need to rope those folks in to the overall multidisciplinary care of people with vascular disease way earlier than I think we do. I think we wait until after we've done something, because like you say, we treat someone, we revascularize a vessel or restore blood flow, and okay, I did my part. I have no reason why you're still having pain, Helen. It's What are you doing? And you put it back on the patient. You almost blame them, for having pain after, I fixed you. And how dare you have pain after I fixed you, And I think the next step should be referral of that person to someone that manages pain. If that's not what you do, there's part of that, the hubris thinking that, you can take care of everything for everyone, but you can't. And there are lots of folks out there who are frankly smarter than a lot of us about issues like pain. I'm not a pain specialist. You know way more about pain than I do, but what I know is that I know where my expertise stops and where the phone call or text to my friend, can be the next step in the care of someone, and I have no hesitation to do that. But I think we need to start doing those outreach types of activities on behalf of these folks earlier than we do.
And I am wondering, in terms of just the vascular issues and the pain associated with that, I would almost wonder that there is such a big push for frontline treatment for PAD, which is the walking and the medication, the overall lifestyle changes.
Mhm.
And there's a huge emphasis on that because for most people with peripheral artery disease in particular, symptoms can, and in most cases do improve with those lifestyle modifications, coupled with the medication, and even more importantly, the walking. And so they hesitate at that point to say, hey, if you don't try this first, I'm afraid to give you that pain medication and get rid of the pain in a using chemicals, right, in a sense. We need to try it naturally first, because if you're masking that pain, will it ever improve? And I think that there's a point to that as well.
Sure.
And I think that there needs to be, hey, they have scales for everything else. I think there needs to be a pain scale when it comes to PAD in particular, to allow vascular specialists such as yourself to safely and legally make those determinations to give them some sort of chemical relief, some sort of pill that can help them. Because if you can, maybe if it's a patient that will go out and walk, that will take those next steps to do their part, right, to become a partner in their health, then why not, alleviate some of their pain so that they can get out walking? It's what I always say when it comes to doing a revascularization, kissing it with the balloon, getting a little bit more blood flow. If this person is willing to walk and they just need a little bit more blood flow to help, alleviate some of the pain and to get them further so they can build even more collaterals more effectively in a faster amount of time, well, then revascularize. But there needs to be some sort of, I think doctors are more comfortable with some sort of scale, assessment chart. Do you think that that is at all possible? Or
Kim, I will tell you what the problem is, why they won't help us. It is because of the young children. They're young. The young ones that are really causing this epidemic of dying from using pain meds.
Yeah.
And it's causing it where those of us who are just literally crippled from it, that they're not willing to help us. That's it. I mean, you know how I feel about my doctors. I love them. But that's why I was going to leave the hospital against medical advice yesterday, is if you're not going to control my pain here, I'd rather be home in pain. At least at home, I can do different things. Here at the hospital, I can't do nothing but sit in this room and roll around and bawl and cry in pain. Yeah, I'm going to leave the hospital. They need to find a common ground where they can tell from the people who need this and the people who are just trying to get it.
Well,
There's a big difference.
The one question we don't ask, Marie, I mean, there's a lot of questions we don't ask, but the one question that we don't ask when dealing with pain is, how is it affecting your daily life?
I don't leave my house. That's how it affects my life.
Right.
I
right.
live, you see this bed I'm in right now? I'm at home and this is where I'm at. My bed is my life.
Right. And that's
because I cannot take, the only way I can walk is if you put me in water.
Yeah.
If you don't have me in water, I can't walk. It's that bad.
And that's the piece that we're not intervening with at all right now as medical providers. What the system did is the system was free flowing. Here's all the opiates that you all can give. And then they came down hard. And I'll tell you, and Dr. Wilson can speak to this too. Providers are scared to death because literally the states will put you in prison as a provider if you overprescribe.
Most providers won't do it. Most people have to go through a pain management now.
But even
that's why I don't understand why pain management is even being like, oh no, I don't want to give you this.
Even the pain management, they're either under a more hyper scrutiny than the physicians that aren't prescribing. And in the state of Tennessee, if you're one of the top 100 prescribing physicians that are providers that are giving opiates out, they will send you a letter and it will say you are being watched. So these people are trying to help or being constantly watched because, they're trying to, they're diverse.
As long as they're helping the right ones, who cares who watches? I said, I was in the hospital. I was in the hospital yesterday. And that's why I told no, I'm signing out AMA if you can't do something because I'm not going to sit here and suffer.
Right.
In a hospital, they should be able to control it without anybody, saying anything. Oh Lord, I can't believe you did this.
Mm-hmm. You would expect so, but and a lot of the aspects, and I'm sure you can always ask for ketamine in the hospital. Some hospitals may say that they don't give it, so then therefore you can just say I need an anesthesia consult for pain control, and then that takes to a higher level of to where anesthesia will come in and give you. We can do a ketamine pain pump, different things like that, but ketamine. When you're maxed out on the other opiates, like there's certain receptors that certain drugs attach to. And when those are maxed out, we can sit there and pour it into your system. It's not going to touch anything. But the nice thing with ketamine is it actually works on a different type of receptor that the other ones don't work on. So sometimes it may be just the smallest dose of that. It makes you feel different than some of the other opiates, but it can take away your pain and it's been pretty effective. So that's one that I would recommend. That's a step I'd recommend in the hospital. They won't tell you that's available, but that's available, is to ask for an anesthesia consult for pain control.
That's a very good tip to have. Thank you.
Welcome.
And Larry, you had a very personal situation in regards to that when you and I first started working together. If you don't mind, do you mind if I share?
Go right ahead.
I had introduced you to an amazing advanced vascular specialist, and we went in and you were, of course, in need of a procedure, but nothing ever happens in a timely fashion, right? So you go in for the consult, then you need to go back in for a blood test, and then finally you get the procedure. And you ended up deciding on your own, because he wouldn't give you any pain medication that you needed to get you through to that point. Sometimes they don't understand, doctors don't seem to understand. It's like every single day in chronic pain, crippling pain, can literally feel like watching paint dry. I mean, time just ticks and ticks and ticks in the slowest manner when you're in chronic pain. And what did you end up doing, Larry, at that point? You said, I can't deal with this pain anymore. And you ended up going to the emergency room.
Yes, I ended up going to the emergency room, which you gave me great advice. Dr. Red, I knew nothing about, but I'm sure you knew more about him than I did. And through the weekend, pain got worse and worse. And I said, well, I'm going to have no choice but to go to the emergency. A great choice at the moment, but a bad one in the end, because I ended up with a doctor. I don't use names to bash people, but he already had insisted on putting in stents in the top of my leg and the bottom. And that didn't work. I didn't hear from the doctor for 2 or 3 weeks. How you doing? Or nothing. That's when I knew I was in the wrong place. When someone don't care about your well-being, you definitely don't need them operating on you doing procedures. And I later, on 2-3 months, I went to Dr. Red. What a big difference. I can put out great names for great doctors. I don't mind. He did a simple procedure, and just went in my foot, went in my calf. I felt, I would say 80% better with the pain situation. And he still didn't give me pain medicine. For some reason, I just said, okay. He said, I can send you to a pain management. It's almost like they pass us off to another person. This person can only do so much. It's almost like an insurance game.
If you listen to these stories and whether it's Larry or Marie or Helen, or I see Heinz is here and Douglas, and is that in every situation, they were not diagnosed in the early stages. When they first experienced the claudication pain, their symptoms were brushed off. They weren't given a regimented walking program and medication and instructions for smoking cessation and other lifestyle modifications during that first consult. And I hear it all the time, doctor, just talk to me. And I think that there should be some sort of extra reimbursement maybe for these doctors, for people with peripheral artery disease, to be able to spend an hour with every single patient with a structured, agenda as to what they need to go over to really help these patients understand what's going to need to happen, the timeline for symptoms improving, what happens if symptoms don't improve over the course of time. And I think that if we do this sooner rather than later, I don't think that the patients are going to get to this point where it turns into chronic pain. So even if you do treat them, even if, as Marie will tell you, even when she did end up finally getting treated, the damage was already done to her nerves. She already pretty much had peripheral neuropathy that was permanent. No matter what the doctor does today or tomorrow or the next day, that pain is not going anywhere. You can get all the blood flow you want now down all the way to the toes, but that pain is now permanent.
I didn't get treated or diagnosed until I had literally gone into the ER, and I was literally in the fetal position in the waiting room of the ER, bawling. And even then, the ER, we overheard the nurse say, she's just drug seeking. It did not happen until it was a cardiologist that came in there and wanted to do an angiogram. And at that time, I didn't even know what they were. Now I'm an expert. But he took me in that room and put the dye in, and he had an ambulance come right in that room and take me off the table and take me lights and siren to the main hospital. And I didn't know until after surgery that they had told my husband, first we'll try to see if we can even save her life. If we can save her life, we'll try to save her life. I was already that severe by the time I found out I had it.
Hi everyone. I'm Adam Franklin. I just want to jump in here. Can everyone hear me? Okay.
Yes.
Yep.
Yeah.
Hi. And so I have a question for Helen here, and also for the group. Helen, you had mentioned earlier that your son, when you were talking your vacation in Canada, and your son didn't think that your pain was as severe as it was. I'm just wondering, what was his reaction once you went to your extreme to go into Walmart and get care through that way? What was your son's reaction going through that?
I think that he was pretty shocked. He didn't realize it was as severe as it was. And I gotta say that the doctor, he actually has the same reaction that my son did. When I saw him a couple of days before we went on vacation, he said, "Oh, I looked at your test results and you're not all that bad." You know, and I said, "I'm in extreme pain." And he said, "Oh, I've seen people worse than you."
Wow. And that's the thing. Also, Dr. Wilson can chime in on this one. the ultrasound doesn't tell the whole story. And I've seen it so many times, even a general, going in there, you go in for the angiogram, you pump in that contrast fluid to visualize the arteries under the x-ray. And even that may not tell the whole story. Listening to the patient's symptoms is what can ultimately help you to determine what's going on and realize something needs to be fixed. In one case I watched where an iliac was 98% blocked, but even in the angiogram with the contrast fluid, the angle of it still showed that maybe there was only a little narrowing. It wasn't until the doctor, he said, hey, watch this. He had a feeling. He put in an internal imaging device known as intravascular ultrasound, or IVUS, that uses those sound waves to give them a better visualization. Went in there, it was like a 98% blockage. And it explained the symptoms. And he was like, this is really easy to treat right now. But if this would have been another couple of months here, he said it would have been a lot tougher to treat. And so he was able to go in, revascularize, do a little roto-rooting, remove some of that plaque, balloon, sent her on her way, and she's doing great, pain-free to this day, months later.
Oh, yeah, that's beautiful.
Yeah.
And so I'm curious,
tell us-
Dr. Wilson, if you find that to be the case in situations, just listening to even Helen on this.
Absolutely. One of the things that they told us really early on in medical school at the University of Rochester was that people will tell you what their problem is if you listen to them. It's like that's 90%. And then the tests basically that you prescribe for folks basically kind of helps to narrow down the possibilities of what could be going on, And so you start with just listening to people, looking at them, putting hands on them, touching someone, like examining them, like bridging that distance between yourself and that person in need by actually just touching them, that does a whole lot, especially first on. And you have the opportunity, because that's how you kind of build that trust that allows you to do the advanced procedures like the angioplasties, the stenting, the atherectomy, the intravascular ultrasound, after you've developed some trust, right? I mean, if you don't trust the doctor, it doesn't matter who they are or what they do. If you don't trust them, you're not going to let them touch you, And so that's kind of first and foremost, establishing some trust, listening to people, and then letting them tell you what is wrong without being judgmental. I think the judgment is where the roadblock goes up in their thinking about how to solve problems for people, is when you pass some kind of judgment and then the problem solving stops, right? Then you've already assessed the situation. Never mind what you tell me afterwards. This is what you are doing. You are drug seeking, or you are making up stories, or you're non-compliant. It is a partnership, right? We can only do what we can do if folks do their part. I often tell people that I'll do my part, but you got to meet me halfway. I know you're a smoker. I'm not going to tell you, okay, if you stop smoking now, we'll take care of it. It's impossible, but we need to come up with a plan together. And part of that plan has to be your smoking cessation. Part of that plan has to be you walking until you get some pain and stopping perhaps. And while we do other things, while we treat your pain with something, while we plan for revascularization, it's a partnership, And so that's kind of my philosophy and approach to people with very similar problems as Helen's,
And Dr. Wilson, I'll add to that too. When you just said a partnership, that is very few and far between that I think that patients and physicians and providers have. I get the impression a lot of times that when patients go to providers, one, they're trying to advocate for themselves, which I love. But two, when we're trying to ask them their problems, they don't always have the best descriptors of what they're going through. So they're doing the best that they can do. But as providers, we're trying to hear it, but sometimes there is that language barrier that's there. But then also, you know, when patients bring in articles and such and say, here, this is what I'm thinking, you know, it's what they feel the most connected with. Most providers won't even look at the articles. They'll just put them down, you know? So it's more so that it's almost like it's an administrator and it's an employee. And the administrator says, if you don't do this, I will fire you. I mean, I've worked with cardiologists for several years they'll fire people all the time, you know, for anything, right? So it's like this, it's this parent relationship almost sometimes, to where really in reality it needs to be a partnership. We need to be representing the people who come to us, who ask for help, and utilizing our skill sets and our specialties to help advocate for them. And I think sometimes as providers, there's just so much stress and so much pressure with trying to, you know, meet all the demands of the current healthcare system, that the providers aren't being heard and the patients aren't being heard. And then the patients are the ones getting hurt.
Right. Finding a good doctor is like one of the most key things you need. And that's like this, just yesterday in the hospital, we didn't even know. When I was going to U of M, I have 4 bypasses. I mean, we did not even know I had. And if it wouldn't have been for them finding the blockage up by my aorta, we wouldn't have never known it was there. That's how they found them. We didn't even know. And that you got to have a doctor who's going to communicate that to you.
Right. No, actually, it's interesting you say that. We've actually been in procedures where I'm there with the patient and the doctor from the very beginning when they're discussing what they're going to do and et cetera. In one case, the patient was asked, have you had any other procedures before? Have you had one of these angiograms? Do you have any stents, anything like that? The patient's like, no, I've been in for a CT and that's it. And then we go in there and there are stents. How does the patient not know? And this person in particular was of able mind, but just did not know. The doctor did not describe what they were doing or what it was. Oh yeah, we're just going to do a CT angiogram, no big deal. Like,
well, and maybe they did, Kim, and maybe they went and did their education in the recovery room when they're halfway narcotized, from the medications that we gave them.
That happens as well.
Yes, it does.
Yep, that's one of the complaints we had last time in February, is they had me signing consent forms, and I don't even remember being at the frickin' hospital.
Yeah. So that could be because of a trauma response, or that could be because we've given you too many medications and we've been highly effective at decreasing your recall, which is good.
I told them I am not allowed to sign consents anymore. No more. You call.
Yeah.
Marie's actually really, really smart. And so also is Douglas. They actually have, advocates. They'll call me, they'll call another advocate, and they'll say, hey, I need you to not only tell me, because I won't remember, not just tell one of my loved ones, tell someone who actually can truly explain to me in detail what may have occurred and can understand your lingo. Because we would rather the doctor be able to talk in regular lingo, because what we find is that some of these doctors are telling the patient, oh, you have a vein problem when it's an artery problem. So we'll have patients come to us, tell us they have peripheral artery disease, but the doctor only talked about the veins being blocked. And that's very odd. One doctor, I asked, why are you talking to the patient about her veins? And he said, well, that's what people understand when they think of their circulation. They think of veins and they just think they're going all the way throughout the body. So I just find it easier. And I said, why don't you talk about the freeway system and tell them you have lanes going north and lanes going south? I mean, it's really not that complicated. And what I find is that I don't care what level of education these patients have, they'll get it if you talk to them and you take the time.
Yeah. Kim, I have to tell everybody, if you don't have an advocate, get one. And I will tell you, Kim is an excellent one, because I found her 2 years ago. She became my advocate instantly. She got me to Dr. Saab at ACB. And I'll tell you what, if I did not ever meet Kim, I wouldn't be here today. I would have already passed from this. I have
He
two legs
really
because
listens.
of Kim, and I have a life because of Kim.
Okay.
But Kim, this might be, I was trying to think about other pain conditions that may be more complex than what PAD and the venous insufficiency is. And honestly, there may not be too many more out there unless you're just looking at the spinal column with nerve compression that way. So, maybe Kim, this is a good challenge for this group to create a pain scale that talks maybe about the quality of pain, the quantity of pain, and then how does it affect your activities of daily living. And I've got connections, and I mean, Dr. Wilson knows all this stuff to where we can figure out how to make this, a valid scale, pain scale, because it's not out there and it needs to be created. But I've got some connections with universities to where maybe we could help create that. So we could put it down on paper and decrease that communication barrier, because it's not just this group that's struggling with pain. It's the entire country, because we put people on them, we took it away, and literally people are dying every day because they don't have the options that they need.
I think that this is absolutely brilliant. And I think that we should start with peripheral artery disease in particular, because I think it's easier to start with one disorder and then be able to have something that can be replicated, right, in a grander fashion, and can even go to where, depending, let's say a person with cancer, their pain, the way they would describe it would be different, let's say, than someone with PAD or even with chronic venous insufficiency. And I think we have a great group here. We have Catherine that could be involved on a steering committee, Dr. Wilson, on a steering committee. I'm sure Marie and Helen would want to be on this committee as patient representatives to help us to visualize it on paper, right? From your experience, how you would describe it. Larry, you as well. You've had the phantom pain even, with one amputation. And Douglas as well. So I think we have a great crew that we can get together and start thinking about how to put this together. Dr. Wilson, is this something that you think that could become something that would be widely adopted?
Absolutely. I mean, there's precedent in other disease conditions like osteoarthritis. There's a classification scheme, a scoring system that came out of McMaster's University, which basically takes into consideration not just the amount of pain, but the impact of the pain on your functional status, right? So how able are you to do your activities of daily living in the setting of this pain? Marie mentioned that her world is right there, the bedroom, right? The bed. So immense impairment of functional status, right? So I think I think that's more useful assessment, of someone's experience with pain and kind of where they are on the pain continuum by taking into consideration the effect on their daily life and their functioning. I think that beyond just a visual acuity scale 1 to 10, when you say, okay, I've got this, but I can't wash dishes because I can't stand on my feet for more than 20 minutes, or I can't go to the grocery store, which is around the corner. I live too close to the grocery store to get an Uber or to get a ride. I usually walk to the grocery store and I can't, and I got to get help, So the functional status assessment, I think, is very important. And it's important to us as practitioners who specialize in vascular procedures to know how much someone's functioning is being impaired, because that'll help us justify the risk of any treatment, right? Because these procedures we're talking about do have risk. But if someone's functional status is impaired because of the pain plus the daily living plus the quality of life and all this other thing, it'll take some time. And I think looking at the history of some other classification schemes and scoring systems could be a guide, but I think those things are used throughout the world because someone took the effort to make them, because of the need to assess more than just pain 1 through 10.
It's a category. We need to make a pain scale, a pain category that someone's in, and it's it's got the complexity as to what it falls under. Yep.
Yes, absolutely. Absolutely, Catherine. Yeah.
I agree with that. And for, I like to say, when, as a patient, when we go into the doctors and you tell them, the first thing they say, how's your pain level? If you say 8 or 9, they take it as, yeah, whatever. I mean, you can see their reaction, like they don't take it seriously. And I'm just honest. When I go, if I'm feeling good and it's a 6, I say a 6. But why is it that doctors want to overlook that you are truly in real pain when you go to them?
Because they've not been properly educated. It's just not there yet. We're just now seeing that mental health and pain are related. There's a part of your brain, it's called the lateral habinula, and it actually shows there's a direct relation there. Most providers, unless you've been down the rabbit holes that I've been down with Google Scholar, looking at all these scientific reviews, most people don't know that. We just know it as a number, and that's all we know. And we've not been properly educated. So it probably takes 10 years for the medical society to accept new. And we're in the transition phase, thankfully, but unfortunately, there's so many people that are in your all same circumstances that are suffering because we're not able to transition effectively right now.
Yeah, and 10 years from now, I'm gonna say I'll be 99 by then.
Yeah.
No,
by that time, we hope to have you pain-free.
Yes,
yes,
we
I'm
do.
gonna be pain-free mentally and physically because I'm the type to fight it and just deal with it and move on.
So I wanted to jump over to Dr. Wilson and also nurse practitioner Catherine Walker for some final thoughts and takeaways overall on this incredibly impactful discussion.
I think more practitioners need to hear from people who are experienced differently with, from a professional standpoint, like around the country, because there's variations in how different conditions are treated in different parts of the country, just as a matter of, fact. Some areas have a high concentration of certain specialists. Some areas have high concentration of advocates, and there are some deserts in both categories scattered around the country. But conversations like this are very, very informative. And I think that, the take home, if I could, prescribe it, is the realization that, you're more empowered than you think, to take charge of your own care. You have certain rights that no one can take from you, regardless of what system your doctor is in or where they have admitting privileges to. You have a right to a second opinion. And I think the more that we tell people that, because that's something that Catherine was mentioning here, in the chat about why people think that way. And we're kind of hardwired in this society to accept the doctor's word as gospel, which it is not, right? And when you're faced with a life-changing diagnosis or treatment, it's 100% your right to question and to ask, for a second opinion. Seek a second opinion. Don't ask them to recommend someone, because they probably won't do that. But it's your right to go on the internet, find someone else in your area who does the same thing, and talk to that person. And second opinion doesn't mean that the opinion you got is wrong. It just means that now you have the benefit of additional information from someone who's also, expert in your condition, in your disease and the treatment of it. And so it doesn't mean that the person that you're talking to initially is on the wrong path. They may very well be, prescribing the right thing, but it's at least worth you being, an advocate for yourself and seeking that opinion and reminding other people who may not have access to forums like this that they can do the same thing.
And you know what they should encourage in medical school? I worked with a heart surgeon who I always admired this about him, but he would always give someone his opinion, but he would tell them every time before he did any type of open heart surgery, he said, go get a second opinion, go get a third opinion, go get as many opinions as you want. I'm giving you my opinion. And when you're comfortable, then we'll actually take it to the next stage. But in the meantime, go see who you want to see. And that's how every physician needs to be is, I mean, it's like, yeah, I know I'm good enough. Right. So I love that about that,
That's right. Yeah.
My final thoughts is thank you very much for the doctors we have today and yourself, Kim, and also Helen. Please don't go out and do anything foolish. Call us.
Call Larry.
Go and call anyone or everyone before you even make a move. If you're thinking about it, call me and I'll say, let's go shoot some hoops. Then
You got it.
I'll show you a few hoop tricks.
I just have to say I'm very inspired by Helen's story and everyone sharing today. And it's the hope, courage, and strength that together we can make a difference.
Fantastic. And Helen, your courage is just amazing. And we hope that your story is going to help so many others. And we hope that through sharing your story as well, there are some folks that are going to find empathy in your situation and get you the help that you need in a timely, effective manner.
Thank you.
This has been a powerful discussion. Again, it's going to be ongoing. And I think our real takeaways from this is we are going to be hopefully starting a steering committee in partnership with Revitalist and nurse practitioner Catherine Walker, also Dr. Ian Wilson, and several of our PAD warriors here, our patients who have been experiencing some chronic pain. And we will try to come up with some sort of scale that could ultimately be widely adopted and help many more patients to come.